righty, go ahead, Dr. Goldman.
So I'm Dr. Goldman. I'm an assistant professor of plastic surgery at UNLV School of Medicine. And today I'm going to be talking about unsolvable problems and how we've advanced to areas now where we can solve them. That includes both treatment of lymphedema as well as breast reconstruction in the radiated patient. So these are our learning objectives. I think they were all sent out. But basically, we're going to go over epidemiology, pathology, and mainstay treatments of lymphedema, advanced surgical treatments of lymphedema, and then advanced reconstructive options and how they relate to psychosocial outcomes for our breast cancer patients and breast cancer survivors, specifically with regard to patients that are radiated. Just to summarize, the things that Dr. Vinosa talked about and kind of start off from there, he really went into the health policy that it's federally mandated for insurances to cover reconstruction after mastectomy as well as all symmetry procedures. And that despite that, we still have not optimized care delivery for a variety of reasons, mainly access and education. And so that's kind of our charge is getting the word out there and let patients know their options. He also went a little bit into each type of reconstruction, and we will kind of review some of those and then go into the next more advanced options. But again, I always like to show the lifetime risk for developing breast cancer is 12%, 1 in 8 women. That really means that breast cancer has probably touched almost every person in the United States in one way or another. So who should be referred to a plastic surgeon? We talked about this a little bit last time, but essentially, if there's no absolute contraindication except for being unable to undergo surgery for breast reconstruction, and that includes age and different health considerations, different comorbidities. And so we consider all patients, and even patients that don't think that they have any options for breast reconstruction. It's still valuable for them to be sent to a plastic surgeon. We might offer some less invasive procedures that may improve their psychosocial outcomes, as well as just providing things like mastectomy bras that their primary care providers or their breast surgeon may not be comfortable sending them out to. Sorry, I'm trying to get this. There we go. So, and all women with a diagnosis of breast cancer should be referred to a board-certified plastic and reconstructive surgeon to discuss treatment options. And I would add to that, it should be a board-certified plastic surgeon or board-eligible plastic surgeon who offers all of the options or is comfortable discussing all of the options. And as we'll discuss a little bit further, the more advanced reconstructive options aren't offered by everybody, and some kind of downplay them. And really, those are becoming more and more the gold standard treatments. So if there was one slide I would want everybody to take something from, it's this, and it sounds like a lot of people on the call already know this. And as Dr. Vinosa alluded to, everybody is important in this charge. This is a multidisciplinary effort to optimize care. And so we need not just all of the surgical oncologists, the radiation and medical oncologists and the surgeons, but also all of the physical therapy and occupational therapy. The patient navigators are extremely important, and they know just how multidisciplinary this care is. And as our colleague discussed, even things like behavioral health can be extremely important in this setting. Care has to be individualized. I think there's a lot of misunderstanding about that. There's no one size fits all, especially with regard to all of the moving parts. And so my philosophy on breast cancer is really, you can break it down into 2 sections, but all of those sections have a lot of moving parts. Those sections would be first survival, and then secondarily satisfaction. Because we need to get rid of cancer first, and then we have to make that patient happy with their quality of life after. And that's different for everybody. From the very first portion of expectations to the very end of dealing with what we've been given, if that includes neoadjuvant chemotherapy or radiation, axial lymph node dissections, and then that all has to be longitudinal. There's not much point in discussing the long-term effects of radiation or lymphedema if after mastectomy and the cancer's gone, we say, okay, goodbye, we're done. So that's why we really have to follow these patients out a long time and consider that longitudinal care aspect. There are 3 main types of breast reconstruction we touched on last time. So implant-based breast reconstruction using saline or silicone implants, and it's the most common form of reconstruction in the United States. Autologous reconstruction uses the patient's own tissue. So that's autologous. It's broken down into pedicled flaps and free flaps. Pedicled meaning that the blood supply is never taken off of the body. So it's just rotated or transposed from one area of the body to another. And then free means we actually take it off and transplant it to another portion of the body to recreate a breast. And then there's combinations. And timing of breast reconstruction can really be any time. So delayed means that the patient had a reconstruction well after their mastectomy, and usually after all of their treatment is completed. Immediate being doing something at the time of mastectomy, and then delayed immediate being at the time of mastectomy, placing an expander or a placeholder, followed by later definitive reconstruction, either with implants or autologous tissue. So as I said, the implant base remains the most common form of breast reconstruction in the United States. The shorter operative and recovery time, simpler procedure, but there is still a long-term need for additional surgeries for implant-related complications. And those can be mechanical, like implant rupture, or physiologic. The body makes a scar around the implant, and that's called capsular contracture. And over time, that scar needs to be removed. Sometimes the implant needs to be placed in a separate pocket. And so that requires further surgeries. And that happens particularly in radiated patients where the risks of capsular contracture and the risks of infection and implant loss are actually significantly higher. That's why autologous really becomes the gold standard when you're talking about a radiated patient. And then there's patients that just don't want to have implants in their body or have implants and would like to be converted to autologous. I'm sure a lot of you have heard in the news talk of breast implant illness, which is controversial in the literature, and then talk of breast implant associated anaplastic large cell lymphoma, which is a implant related cancer that can happen. Has only happened with textured implants, and both myself and Dr. Benosa no longer use textured implants, as really has been the pendulum swing for most plastic surgeons. And this is essentially what the breast implants look like. Usually, historically, they were placed under the muscle, so there was a little bit more coverage of the implant, a little bit less rippling, but it's essentially went skin, a small amount of subcutaneous tissue, muscle, and then implant. And that's very different than your normal breast augmentation, where you may or may not put it under the muscle, but you still have that gland well over the implant, which makes it much more difficult to see the implant itself. One advance we've seen a lot of is nipple sparing reconstruction and the movement towards pre-pec, where we put the implant on top of the pectoralis muscle. And so that's changed a little bit of our abilities to provide an aesthetic reconstruction with implants. And then using the acellular dermal matrix, which is a biologic mesh, not FDA approved, so the mesh people can't market it anymore. That's allowed us to decrease capsular contracture rates and to control the pocket a little bit more. So we're able, again, to provide an aesthetic reconstruction. On the top, you're seeing kind of a dual plane where they put the implant half under the muscle and half under this mesh. On the bottom there, you see a total pre-pectoral reconstruction where it's all on top of the muscle, and that decreases our need for things like muscle relaxants and pain control after surgery. And these patients generally will go home day one after the placement of either an expander or a direct implant. And then this is really the meat of the talk. So we'll be talking a lot more about autologous reconstruction, where we're utilizing the patient's own soft tissue to reconstruct the breast. Again, it is the best option for patients who have had or are planning to get radiation therapy. And this is where you see the biggest disparities in places that are underserved, specifically with microsurgeons. So these procedures do take longer, and they do require a higher degree of training. And so in places where there aren't many of these people, you see a huge number of patients that are radiated getting implant-based reconstruction, which is suboptimal. The most common autologous tissue transfer, free tissue transfer, is the deep inferior epigastric artery perforator flap, or commonly referred to as a deep flap. So tissue is removed from the abdomen with blood vessels, and then it's reattached to blood vessels in the chest, and we shape a breast out of it. It requires an adequate amount of abdominal tissue to form the breast. And there's a little bit longer recovery. This is actually numbers that we used to quote to people. So in hospital for about 3 to 7 days. I used to tell people in the ICU for 1 to 3 days, in the hospital for 3 to 7 days. The operative time is usually about 8 to 10 hours. And we've gotten so efficient at these surgeries. Our operative time is usually about 6 to 8 hours now. And several of our last patients have gone home post-op day 2 with enhanced recovery protocols and never even go to the ICU. So it avoids short and long-term related complications of implants. And again, we've discussed pedicled versus free, requires specialized training. And deep flaps can be performed immediately or at the time of mastectomy or in a delayed fashion. So after the patient's completed all of their treatments, they're flat for a certain portion of time. And what we found in the literature is that patients that have immediate versus delayed, actually their patient satisfaction levels out at about 1 year. And so it doesn't make a huge difference in patient satisfaction, but it does decrease the rates of complications. Obviously, if you don't place an expander, you can't lose that expander. This is just an example of a pedicled flap. So this is kind of something, the top one is called a pedicled tram or transverse rectus muscle flap. And it's kind of old school because you had to take the entire muscle, and that left your donor site without muscle there and increased your risk of a hernia or a bulge down the road. And that kind of slowly became a free tram where we take it off and have a little bit of more rotational abilities to shape the breast, and then evolved into the deep flap where we actually don't take any muscle and we spare as many nerves as possible. That way the risk of hernia and bulge goes down significantly. In the bottom there, you're seeing what both myself and Dr. Menosa use as sort of our salvage flaps, or for patients who aren't candidates for a deep flap. That's a latissimus flap. So we actually take skin and muscle from the back and are able to replace radiated tissue with that and give better soft tissue coverage over a final implant. So when we're talking about free tissue transfer or microsurgical breast reconstruction, this is sort of what we're talking about. So this is the microscope on the very left with the 2 operating microsurgeons there. You can see there's a screen there. We almost always have the screen up so that trainees and our scrub techs can see exactly what we're doing, up to about 40x magnification. And on the very right there, you can see that those are the free flap vessels on the very top, and the recipient chest vessels on the very bottom. And that green background, those little squares are cross-hatched with about 1 millimeter. On the left, there's a venous coupler. So we have a little device that allows us to put the vein together a little bit more simply. The artery, unfortunately, isn't as compliant, and so we have to hand sew that. And you can see there's some 9/0 sutures holding that artery together. So this is sort of an example of advanced breast reconstruction. So you can see we, in a similar fashion to a tummy tuck, take an ellipse of lower abdominal tissue. We dissect the vessels out through the muscle and then transfer that up to the chest and attach that to the internal mammary vessels of the chest or the thoracodorsal vessels of the back. And it provides a soft, supple reconstruction with a higher patient satisfaction. And there's been continued advancements even just from that. So you can see on the left here, what you're looking at there is a deep flap that's also inclusive of lymph nodes. So patients that have lymphedema and require reconstruction, we can actually transfer lymph nodes with the deep flap up to their axilla and replace some of that deep system of lymph nodes, which we'll talk about a little bit more once I get to lymphedema. In the middle there, you can see the free flap itself. And so you can see that the perforators are there with the vessel that we're going to attach to the chest, and that's still in the abdomen there. You can see there's no muscle on the vessels. And I think important to point out is that you can see in the hand of the surgeon there that that's a lot of tissue. That's probably about 1,200 plus grams of tissue, or 1,200 plus cc's. And the largest silicone implant is 800 cc's. So specifically in the larger patient, larger BMI, this is a much better surgery because a 800 cc implant, for better or worse, is going to look like a drop in the bucket. And then you can see on the very right there, that's a stacked flap. So actually that's both flaps taken as one and both hooked up. And then you can also see that there's a nerve there, which we're able to co-opt into the chest and provide a sensate reconstruction. So that's a large volume reconstruction with sensate reconstruction via a nerve coaptation to the fourth lateral thoracic nerve. And I don't think anybody's thinking that this is going to provide like erogenous sensation for the breast, but I think what it does is provide some sort of proprioceptive sensation, and so people can feel their chest in space. And what we found is that satisfaction goes up significantly with nerve coaptation. So why don't we always do the simplest reconstruction? Well, as we've said, the risks go down with autologous versus implant-based reconstruction. And that's particularly true in radiated patients. And then satisfaction goes up. So increased patient performance, both general and aesthetic satisfaction. And then when we're looking at types of autologous, there's just different complication profiles that I sort of discussed with most of my patients when we're looking at pedicle versus free tissue transfers. This is a study out of Harvard. It showed basically on the very left is blue, that's the implants. Latissimus is red, so that's a pedicled latissimus flap. And then you get into pedicle tram and deep flaps. And you see that in the abdominally based tissue transfers, you have a much higher rate of general and aesthetic satisfaction. And you can see those questions that they look at on the left there. And so honestly, I think general satisfaction is the most important. So would I choose to have this breast reconstruction again? I would definitely choose to have this type of reconstruction I had. I'm satisfied with my reconstruction. And you can see that obviously there's a p-value of less than 0.001, but you can see that the satisfaction is significantly higher in the deep flap group and levels out a little bit in the deep flap versus pedicle tram. But again, your pedicle tram increases your risk of a bulge hernia down the road. When we're looking at which breast reconstruction type has the lowest complication rate, this is a paper out of Mayo Scottsdale with a couple of our colleagues, Dr. Rebecca and Dr. Casey. And I think it basically shows that autologous tissue transfer has the lowest rates of complication. This is something that I quote to patients. And I can tell you that if we go back to the satisfaction aspects of it, there is not a single paper that will say that implant-based reconstruction has a higher satisfaction rate than autologous. There are papers that say that it's stable over time, that you can certainly achieve a reconstruction in any setting, but autologous has always come out on top in terms of patient satisfaction. Now there's papers showing that it comes out on top in terms of lower complication rates. When we're looking at disparities in our patient populations, this is a really nice paper that showed the impact of insurance payer on type of breast reconstruction. A big joke for us is that most of the microsurgeons are at academic institutions that serve underserved populations. So if you were to look at the deep flap as sort of the gold standard, high complexity but high reward surgery, you would find that a lot of the people getting those flaps are Medicaid patients, where privately insured patients are going to private practitioners that don't perform this surgery and sometimes don't include it as part of their informed consent. And they have a much higher population not receiving it, especially in areas where there's not a high volume of microsurgeons available. And so that's what we've seen in the community in Nevada.
Dr. Goldman,
yes.
Just one question here that's come in. What are the risks of lower extremity lymphedema when moving lymph nodes to the axilla during a DIEP?
Yeah, so that's a great question, and I'd say early on the risks were relatively high. I mean, I think one patient who gets lower extremity lymphedema trying to solve upper extremity lymphedema is probably too high. Now we do a lot of reverse lymph node mapping in order to make sure that the nodes that we're taking aren't the nodes that are draining the lower extremity. And so that chance goes down extremely low. And so when we talk about other options for lymphedema, the groin is actually not my favorite, again, because of that chance of secondary lymphedema in terms of donor site. So I prefer areas like the supraclavicular or submental regions to transfer nodes from for that very reason. But reverse mapping really has changed that playing field. And I think where we were very tentative after we started seeing secondary lymphedema early on, now we're a little bit more bold in going ahead and taking those lymph nodes, just making sure that they're not the draining basin for the leg.
Thanks, Dr. Benosa also shared some comments through the chat box.
Yeah, that's a great question and a really important one. So again, when we're looking at the longitudinal care of these patients, we have to consider the effect of reconstruction on their cancer care. And this paper and another will basically show that if you place an immediate expander at the time for a patient that's going to receive radiation, there's a high risk of delaying their cancer treatment. And I'd say across the board, even if patients desire to have an immediate reconstruction, if I say that there is a chance that this will delay your cancer treatment, most of them want to take care of cancer first. And especially if I can say, that your outcomes down the road, 1 year out, are going to be the same as somebody who had immediate, that really resonates, I think. And most people choose the reasonable path of safety. Excuse me. This is another one. This is an ethics paper actually looking at the effect of immediate breast reconstruction on radiated patients that basically establishes that or posits that it's unethical to place implants in a patient that requires radiation because you may be doing them harm by delaying their care. So kind of in summary, there's a substantial psychosocial benefit in patients receiving breast reconstruction. Despite the Women's Health and Cancer Rights Act federal mandates, many women are unaware that breast reconstruction is an option and definitely unaware of some of their advanced reconstructive options and the data that supports them. Providers really need to be aware of this discrepancy and provide education or referral to somebody who can. And all women with the diagnosis of breast cancer or genetic predispositions should be referred to a plastic surgeon so they can have these discussions. And hopefully to somebody who's willing to have a discussion whether or not they provide all of the options. This might be a good time to take just some brief questions, or we can save them till the end and I can go into the lymphedema section.
Yeah, I think Dr. Goldman, let's keep moving here and then we'll
Right.
have some Q&A at the end.
Yeah, sounds good. So lymphedema, I'll say, I think is the most undertreated and underappreciated chronic disease in all of the United States and probably the world. Just a brief anatomy. So everybody's kind of heard of their lymphatics. There's a superficial and a deep system that we don't really understand, to be honest. But basically the superficial and deep system don't have a ton of connection between the two. And then the superficial system includes this subcutaneous tracts as well as a dermal or subdermal system that it can kind of backflow into, and that's the crux of lymphedema. This is a diagram you can kind of see in these like blue lines. That's where your lymphatic tracts lie. And so the problem for those unaware are that you have a deep and a superficial system, and when that deep system takes a hit, such as removing the nodes during breast cancer surgery or radiation, normally the superficial system will take over it and it will be adequate flow. But for whatever reason, in some patients, it's not adequate flow. And what we see is that backflows into the dermis and into the soft tissues, and they get lymphedema and these swollen limbs. So it's a condition that results from impaired flow of the lymphatic system. Symptoms include swelling in one or more extremity. That can range from mild to severe. It can be disfiguring and can really limit activities of daily living, as well as cause complications such as infection. Primary lymphedema is present at birth. Secondary develops as a result of damage or dysfunction in the lymphatic system. And in the United States, breast cancer treatment is the most common cause of lymphedema. The epidemiology is extremely difficult to quantify because nobody's following these things, and I think that's another point to the need for true following longitudinally of our patient population. There's 3 million people in the US, 90 million people worldwide suffering from lymphedema. And the changing landscape of our treatment of breast cancer also affects the changing landscape of lymphedema. So as axillary lymph node dissections or complete dissections have decreased after Z11, and again after the Amorose trial, which sort of transitioned it to more radiation, we're seeing changes in our lymphedema patient population. And so, kind of why should we care? Obviously, we care because of our patients, and previous research has shown up to 50% of breast cancer survivors develop lymphedema, 32% with persistent swelling at 3 years. So it can decrease or go away over time. Breast cancer survivors who develop lymphedema report lower quality of life, higher levels of anxiety and depression, increased likelihood of chronic pain and fatigue, and greater difficulty functioning socially and sexually. And that's from the Journal of Clinical Oncology in 2016. And then, from an economic standpoint, lymphedema boosted the 2-year postoperative medical costs by about $15,000 to $23,000, coming from office visit, treatment of infection, mental health services, and including prescriptions for antidepressants. And a lot of that is shouldered by the patients themselves. So the Lymphedema Treatment Act has kind of sat in Congress for almost a decade now, I believe. And it's basically trying to get a Medicare standard statute that would show that all insurances should be covering all treatments for lymphedema. And I'll tell you, very, very honestly, that the biggest difficulty in starting a lymphedema practice is achieving payers that will recognize it as a true medical disability, which I think it very clearly is. And so a lot of these patients shoulder the burden of the cost of their compression garments, the cost of their therapy, and sometimes the cost of their surgeries. And obviously some can't. And that has a lot to do with the compliance that we see. When we look at timing of lymphedema, this is a big question that I get all the time from both patients and practitioners. So estimated about 60 to 50% of lymphedema in patients after a mastectomy. That's in different studies, and the range is so wide because they're all looking at different patient populations. Median of 4 years follow-up in this particular study, 13.7% lymphedema incidence, which is essentially what I'll quote to patients. There's a peak hazard period of 12 to 30 months, and risk factors include BMI greater than 30, axillary lymph node dissection, and regional lymph node radiation. From other studies, we also know that number of nodes removed, it's again controversial, but anything from greater than 3 to greater than 22. I usually tell people the greater than 10 to 12 has a increased risk of lymphedema. And diabetes we know as well. Chemotherapy has been shown, both adjuvant and neoadjuvant, to be a risk factor, but wasn't significant in multivariate analyses. So I think something that's interesting is that when you look at axillary lymph node plus radiation, you get about 30% lymphedema rate. Axillary lymph node alone, we're just removing the lymph nodes, 25%, and then just radiation alone, you get about 12%. And the interesting part of this is the peaks of when you're seeing this lymphedema. And this again highlights the need for longitudinal following of patients. But for patients who are physically having the lymph node basin removed, you see early lymphedema. So usually that arises at about 6 to 12 months. And that's the group that had a completion dissection without radiation. When you combine the two, you see that about 18 to 24 months. So you're seeing the effect of the early lymphedema plus the radiation. And then when you look at patients that just received sentinel lymph node biopsy and regional lymph node radiation, it's not till 3 to 4 years that we're seeing their lymphedema. And that's from radiation fibrosis of the lymphatic tracts. And so, I think, again, the AMROS trials shifted some of our care, and more trials are doing the same, towards radiation instead of taking out all of the lymph nodes. But what we're seeing is, even though there's a lower rate of lymphedema, patients are getting it later. And so we're just shifting the time period. So this is an example of patients with lymphedema, and you can see them going from A to F with increasing staging. And this is all 3 of the other staging criteria. And I think you can see that, I tell people all the time, same as with osteoradionecrosis, when there's this many staging options, then we really don't understand the pathophysiology that well, or we're grouping a lot of people together, which is probably an aspect of both with regards to lymphedema. When I'm seeing these patients, I've kind of, the first patients I saw in my practice, honestly, a lot of them were not lymphedema patients. Some of them were CHF exacerbation or, kidney problems that were causing their edema, not necessarily lymphedema or lipedema. And so I always tell practitioners to start out with lymph scintigraphy. It's a gold standard, and it basically shows that the radio tracer is getting taken up into the lymphatics, and then they take another time point and see if it's gotten into the axilla in an appropriate amount of time. And that's pretty sensitive and specific for lymphedema. The other 2 things that I commonly use are MRI, not necessarily MR lymphangiogram, but just MRI or MRI venogram to see if there's any compressive factor or scarring that's causing some of the lymphedema in the axilla, in the armpit. And then ICG or immunofluorescence is another mainstay in terms of deciding what kind of treatment to move forward with. So this is ICG or photodynamic eye or near infrared. And basically in real time, I can inject the patient's web spaces between their fingers with some indocyanine green, that's ICG. And then in real time, watch it be uptaken into the lymphatic channels. And this is essentially what you'll see. And it's one of our grading systems. And so what I use to decide if a patient is a candidate for a lymph venous bypass versus a lymph node transplant. So, in A there, you can see a normal lymphatic trail. You can see the lymphatic tracts going all the way up to the arm. In B, you can see that kind of stopping and looks like a little stair step. In C, you see what we call dermal backflow. And then in D, you're starting to see this kind of stardust pattern or diffuse dermal backflow. And so, in the patient who's B and they still have tracts, I can reroute that flow into a vein. In the patients who are C and D, they don't have any tracts for us to reroute. And so what we're going to need to do is bring in new lymph nodes. And this is, again, a good example of that staging pattern. That's the ICG staging pattern that I use to decide. So when we're looking at current treatments, it really follows this spectrum. And I think, it sounds like there's a couple people on here who are very familiar with lymphedema. Douglas is at a place that has 5 lymphedema therapists. I had a hard time finding good lymphedema therapists to send to, but conservative management is the mainstay of treatment, 100%. It is the first starting point. We don't jump to surgery. And in my practice, you have to have either plateaued on conservative management after 6 months, or have failed conservative management. That includes complete decongestive therapy, bandaging, compression garments, manual lymphatic drainage, exercise and self-care, and lymphedema therapists are really the gurus in this space. And I essentially, wait to hear from them that the patient is plateaued or has failed management. And then that's when we start moving forward. Historically, tissue reduction surgeries were the mainstays of treatment. That includes liposuction and then just tissue reduction. So pretty morbid procedures, the Charles or modified Charles procedure, or just removing tissue like a brachioplasty would or an abdominoplasty. Axillary scar release is another option in the appropriate patient. And then lymph venous bypass and lymph node transfer are sort of the cutting edge treatments that we're moving towards now. I see some comments coming in. Should I check that out or save it to the end?
Yeah, I think we're about at time here, Dr. Goldman. So if you can
Okay.
maybe kind of summarize and wrap up for us, then we'll get on to the questions.
Okay. Well, I just want to get into sort of real quickly, what we're offering now. So who gets surgery from me? That's patients with lymphedema persisting greater than 3 to 6 months after complete decongestive therapy, recurrent bouts of cellulitis. If they have early lymphedema, they get a lymph venous bypass. If they have late lymphedema, they get a lymph node transplant. Sort of like we discussed. And contraindications would be active infection, untreated or uncontrolled primary cancer or local regional recurrence, and those medically unfit to undergo surgery. We're talking about super microsurgery here. So, as opposed to the deep flaps, we do that with 8 or 9-0 suture, which you can see on the right there. The lymphedema surgery is done with 11-0, and that's a human hair going up the center there, just for a little bit of scale. These are my preferred donor sites. So again, on the very right, I'll take it with a deep flap and include that into the axilla, or the supraclavicular lymph node basin, which has an extremely low rate of causing upper extremity lymphedema, and then the submental lymph nodes, which are right under the chin and hide really well the scar. This is an example of a lymph venous bypass. This is some of the results that we've seen at Sloan Kettering and MD Anderson. On the left there's a patient who had a liposuction alone, and that was followed by a lymph node transplant. And on the right there, that's a patient who had liposuction, again, followed by a lymph node transplant plus lymph venous bypass. I think important for people to know, too, is the option for prophylactic lymph venous anastomosis. So at the time of axillary lymph node dissection, I'm actually reconnecting their lymph tracts when they're having that completion dissection at the time of their mastectomy. And that's been shown in patients that are just having a completion dissection to decrease their rates of lymphedema by 7-fold. And so really, I think we're moving toward this being the standard of care. And then in patients getting a axillary lymph node dissection and radiation, it decreases it by 3-fold. Again, we can reread, but if the flow is still going to be hit by radiation, it may still fibrose as well. But that's still a significant decrease in lymphedema and a reason to be offering this immediate reconstruction of lymphatics. Just for, again, a little scale, this is one of the, so that's the axilla, that red area. You're looking over my shoulder. This is sort of right in the hands. And then this, again, is the 1 millimeter cross hatches. And so you can see that these lymphatic tracts are about 0.4, 0.5 millimeters at best. Overall, post-op management, there's a decreased need for compression, decreased incidence of cellulitis. And we're looking for about a 10 to 40% reduction in limb circumference. It's not a shocking change in their lymphedema. The future is bright. There's a lot being done in terms of medical therapeutics for lymphedema treatment. And then, do I go over these or?
Yeah, let's address the answers to those questions that we asked earlier.
Sure. So the mainstay of lymphedema treatment, as I noted, is definitely decongestive therapy. And like I said, the first step for me is to make sure that the patient is being seen by a lymphedema therapist, has either or a daily or pneumatic compression, and is compliant with those things. Again, very difficult in a desert setting. Patients who have undergone mastectomy with radiation have the lowest complication rates with implant-based reconstruction. That's false. Replacement of radiated tissue with autologous tissue leads to lower complication rates and increased patient satisfaction. The patient undergoes mastectomy and axillary lymph node dissection. She presents 3 years later with lymphedema of her upper extremity. What is the best next step? Again, I would send them to a lymphedema therapist, but that's not one of the answer choices. So with regard to surgical treatment, the best next step would be staging via imaging or ICG. So thank you guys for listening. I'm happy to answer any questions. And then I do have a small, very short case if y'all just want to see kind of basically what a before and after looks like for one of our deep flap patients.
Sure, yeah. Thank you, Dr. Goldman. So we are over time, folks, so we understand if you need to leave, but we will be here to answer questions, and we'll review that case with Dr. Goldman in just a moment here. So we appreciate if you're interested and still want to stay on with us. If you do need to take off, I sent out a few links through the chat box. The first one is our website for this series, and you can download the slides there, and as well as see our upcoming dates and topics for the series. The next link in there is to claim CME or CU credit. So that's AMA PRA Category 1, Nursing, MFT, and CPC credit that we have available for you here today. So make sure if you need any of those to submit that evaluation to us. And then the last link is to submit a case. So Karen, I know you mentioned we may have a case for our next session. I'll follow up with you over email just to see how that's going. But we do have some slots still available in the later sessions in this series if you do want to present a more formal case to the team here. So please use that link and send that case in. So a question that came in here from Amy, do you have a process in place to send your patients to prehab and or lymphedema education prior to any reconstruction? What advice can you lend to increase earlier referrals for better multidisciplinary management?
Yeah, so I would say that, with a lot of, obviously, like I've talked about with all of breast cancer treatment, multidisciplinary care is probably the most important part, and also in an area where it doesn't exist, one of the more challenging aspects of it. So I now have 2 people that I'll send to and a couple of private lymphedema therapists that I send to. And as I said, this is the most important part, and it's the first part of treatment of lymphedema. So for me, it really does. It's not even prehab, I would say, because I'm not necessarily getting all patients ready for surgery. I'm really trying to get them treated so that they don't need surgery. And so I think building that program is the most important part. It's easier in cities where it's already more well developed or that those services are more available. But that's the slow process, I think, of building a program. If tomorrow I could have a staff of multiple lymphedema therapists, physical therapists, a patient navigator, that would be, and then the other aspect of this is the difficulty with getting the patients the compression that they need with the cost of those compressive devices if their insurance doesn't cover it. Again, sort of highlighting the importance of the Lymphedema Treatment Act.
Thanks for your question, Amy. A question from Dr. Bien asking about if you could share instructions on referring non-cancer lymphedemas.
Yeah, so I've started out our program focusing on upper extremity post-mastectomy lymphedema. And so I do accept patients that have lower extremity lymphedema or lymphedemas that are, primary or early secondary. And I have a protocol that I can definitely email out to. Is it okay to email to you?
Yeah, certainly. If that's all right, if we can post that to our website.
Yeah, absolutely. I have a protocol that basically, and like I said, I started out just seeing anybody who was referred for lymphedema, and I realized very quickly that was a sort of a mistake, and I was spending a lot of time doing medicine, and you don't want your plastic surgeon to be your medicine doctor. And so I put together this protocol so that medical people could work up the patients to make sure that they don't have another cause of edema, and we weren't wasting anybody's time in that process. They weren't coming to me and I was telling them, hey, this could be cardiac or kidney in nature and not necessarily lymphedema, or getting, or I would send them for lymph scintigraphy and they come back and their lymph scintigraphy was completely normal. I just had a patient yesterday that I told that to, and I think, it's hard to tell them that yes, this is a good thing and a bad thing, right? This is a good thing because it's not lymphedema. It's a bad thing because now we don't know. And so then they just end up getting sent back. So I do have that protocol, and I can have our office send that over.
Yeah, I just have a guy who has a unilateral elephantitis type of a lymphedema
Yeah.
that keeps having recurring cellulitis in the area. So
Yeah.
I just didn't have any medical options for him.
Yeah, absolutely.
All right. Any other questions or comments from the group? And before we move on to reviewing that case? All righty, Dr. Goldman, if you want to take us through that case, maybe in about 10 minutes, 5 or 10 minutes here.
Yeah, it'll be like 2 minutes. It's just
Okay.
it's basically showing exactly, like what we do in our patients, so that y'all have a better idea of sort of the outcome. And so this is a 43-year-old female who was referred to me for left breast cancer. Plan was for bilateral mastectomies. I had the long discussion. So I kind of tailored my discussion from when I learned from Dr. Benosa, and then what I learned from my fellowship in addition. And we had discussed that she was a good candidate. She has lower abdominal adiposity. So she has enough in her lower abdomen to make to shape a nice breast out of. She didn't want to be huge in terms of her bra size, and she wanted to, but she did still want to look appropriate for her body habitus. And she had 2 children, non-smoker, after a long discussion of delayed versus immediate reconstruction. So we discussed basically placing an expander at the time of surgery. Her nipples were a bit too low to do a nipple sparing mastectomy. And so I could place expanders at that time, and she understood that could delay any of our other treatments if they were required. And so we decided not to move forward with a immediate delayed reconstruction. So no expander. She didn't want to incur that extra risk in case she got radiated or needed further chemotherapy. And so she came back to me. They come back to me about 4 weeks after mastectomy, and this is what she looked like. She had lost a little bit of weight, but still plenty of lower abdominal tissue to reconstruct her breast. She had a good amount of remaining skin there, but it is scarred and sort of unsightly at the transverse mastectomy scars. And so we waited about, I usually wait about 3 to 6 months before planning to move forward with the deep flaps. I do, in a standard fashion, get a CTA of the abdomen to make sure that, and the chest, to make sure that the vessels that we need are there. Obviously, we pay close attention to the scars, and you can see she has an upper abdominal scar there from a previous laparoscopic surgery. But that had no effect on her blood vessels that we need in order to do the surgery. And so we moved forward, I believe, about 6 months after her mastectomies. And this was her final outcome. So this is 3 weeks after her deep flaps. She left post-op day 2. Because of the laxity in her skin, we were able to get a really low abdominal scar. I wouldn't say that these are necessarily, these are very nice results. These are not the average results or the average patient. She's sort of the ideal patient. Enough volume of her lower abdominal tissue to make a nice sized breast that was the size that she wanted. You can see there's a little bit of delayed wound healing along the lower abdominal incision, but overall, she's extremely happy. She has a nice flat tummy, which is sort of a secondary gain from the surgery. Normally, when we're taking, as we discussed with lymphedema, when we're taking nodes from one area, there's always a risk. The risk here is abdominal bulge, not really a hernia, because we don't take any of the muscle or the fascia overlying the abdominal wall. But the sort of secondary benefit is that you get rid of all that lower abdominal tissue. And then a nice shaped breast and symmetry. Most patients I do say will need some sort of scar revision, outpatient surgery. So I don't usually try to sell people that this is a kind of one and done. And then if she would like to have a nipple reconstruction, we can do a small flap on the deep flaps to give her some nipple projection. And then most of our patients now have moved to getting 3D tattoos for their nipple reconstructions. Or since we're in Vegas, they just get huge tattoos of whatever they like because they're no longer constrained to the normal body shape.
All righty. Well, thanks for sharing that case with us, Dr. Goldman. Any questions or comments from the group regarding this or anything else we've addressed here today?
Just gonna ask real quick, what's the risk these days with tissue necrosis, both to the breast and the abdominal after this? I know it's gone down as the procedure's been perfected, but.
So tissue, so are you talking about fat necrosis?
Yeah, yes.
Okay, so we really break down sort of what we would kind of consider the more catastrophic, flap complications into a total flap loss, which, I basically tell patients we have about 1 to 2 per year. So, and we do about 100 of these per year. So I expect about a 1 to 2% total flap loss. And that's usually due to some underlying clotting disorder or something we don't understand in the patient. But then we lose the flap, and I usually will replace that flap with a back flap while the patient's in hospital, so they always go home with a breast. So about a 1 to 2% risk of total flap loss. Fat necrosis, it's harder to put your finger on that. I'd say there's maybe like a 5% chance of fat necrosis to some extent. Usually it will soften over time, and then when we go back and we're doing small scar revisions, or if they need some more upper pole fullness, or desire to be bigger or smaller, when we're making those fine adjustments, we can do a little bit of liposuction, and that will usually take care of the fat necrosis. So that's not usually a huge downstream problem when we're talking about that tissue loss. Again, and the other side of that is, as you've said, we've become more advanced and more elegant in our taking of those, harvesting of those flaps, and so we always get a CTA. So we, not just so that we can make sure that the vessels are there, but Dr. Benosa and I will actually look at the branching pattern of those vessels. So there may be a vessel lying at the very edge of the flap, and that vessel might go all the way to the edge of the flap, to the corner of the flap. Whereas there might be one right in the middle that kind of peters out, 3 centimeters away. And then we would choose to do the one that has a really favorable branching pattern. And that allows us to make sure that we're feeding the entire flap with a good blood supply and decreasing the risk of fat necrosis.
Right. And just to echo Dr. Golden's point, I think the CT angiogram for the preoperative planning has significantly decreased our rates of fat necrosis, just because you're able to select the most suitable perforators. And even if we don't see suitable perforators for a DIEP flap, what we'll do is we'll end up taking several perforators and more muscle, just to decrease those rates of fat necrosis to minimize that complication.
Oh, I have a question. So I just found it really interesting that you can see that you've seen almost more, it sounds like, Medicaid patients that can have these surgeries just because of that you're a university setting. So patients that do have Nevada Medicaid, we can refer them down to you guys?
Absolutely.
We're an academic center. We see anybody who walks through the door. We take care of patients. So we're happy to see anybody.
I mean, this just kind of goes where the education and everything matters so much. Even when we look at our data, particularly in our own backyard in our city, we've seen the rates of patients that have Nevada Medicaid, or what most people would consider to be lesser forms of insurance, have higher rates of autologous or more complex reconstruction, because we offer all options to everybody. Whereas some of the better insurance rates have, more ingrained referral patterns that refer to doctors that only will offer one, or will end up sending them out of state for the more complex things. We've even had, different breast cancer reconstruction awareness and breast reconstruction groups that have said, oh, if you want to be part of our group, we require you to do at least one Medicaid patient a year, which is almost unheard of in other states. And we're doing Medicaid patients probably 2 or 3 times a month. So we mean what we say when we say we take all comers and we offer everything to everybody. So
that's awesome.